Catherine. I am one of the nurse practitioners with the trauma burn team. You will see myself and my colleagues around, and we are in the emergency room, in the PICU, on the floor, as well as in clinics. So my task today was to talk about burn basics, which is a lot of information. I realized as I was going through this, because I've given lectures before and more focused, but we're going to try to do a full overview. So our objectives, we're going to talk about burns, common mechanisms, key components of a burn assessment, different treatment options, education, as well as burn prevention. We may not get to burn prevention depending on how we're doing with time. So, just a minute. So burns by numbers. Annually, there are over 250,000 pediatric burn injuries. Here at Children's, we see about 2,000 visits a year. This includes visits of patients in the emergency room, inpatients admitted to the ICU, to surgical care, as well as outpatient burn clinic that we have 3 times a week here at Children's, as well as a clinic that is staffed at Friendship Heights. And we'll go into more about that at the end. I just wrapped up burn clinic today, and it is a busy, busy clinic. So who gets sent to Children's National for a burn injury? Below, there's a list of guidelines here that who gets referred to a pediatric burn center or a burn center. This includes any injury that's greater than 10% total body surface area, any injury regardless of size that's concerning for a full thickness injury, certain locations, including the face, hands, feet, genitalia, any burn that crosses a major joint. Another thing that we see are burns that are concerning for abuse, circumferential burns, patients with other comorbidities, patients who are admitted to hospitals that are not qualified, do not have qualified pediatric providers. They also send children to a pediatric institution. And then this is a pretty broad statement, but is a lot of our patients, which is any patient who will require special social, emotional, or rehabilitation. Mechanisms of burn injury. Below, we have our list of how kids sustain burn injuries. Our most frequent mechanisms are scald and contact burns, but they can also be caused by flame, a mechanical injury, such as like a friction burn. We'll go more into that, chemical burns, as well as electrical burns. How hot is too hot? Here is a list of common temperatures that we see in our household that may be causing burn injuries. Serious burn injury only takes 1 second at 155 degrees Fahrenheit. So it's important to remember burns happen fast. Burn accidents can happen to anyone, even in the safest environments. Safe bathing water is 100 degrees. It's recommended that hot water heaters are set to 120 to minimize risk of burn injury. But you can see, so if it only takes a second at 155 degrees, an oven is 400 degrees, a stovetop is 300 degrees, so it is fast. Scald burns. What are common scald burns? We see scald burns that are from soup, tea, coffee, water, baths, cup of noodle soup. These are all frequent mechanisms of injury for patients seen here at Children's. A common toddler scald pattern is a burn that hits the face, chest, shoulder, and arm, often the abdomen as well. And this can be seen here in this little toddler reaching up to the counter to grab something, not knowing what it is. We often see kids who reach up on counters, tables, and pull things down on top of them. Another injury that we see a lot are cup of noodle soup. These are really hot. I'm going to say last week for the first time in maybe like 15 years, I had a cup of noodle soup. It was a crazy day, and the cafeteria was incredibly busy and long line. And I went to Walgreens and I got a cup of noodle soup, and I couldn't believe how hot it was. I'm not just saying that. They're top heavy. They spill easily. Kids are often using them or making them themselves as like an after school snack. We see kids that put them on their lap and they spill. So this is a frequent scald burn that can be pretty severe. Contact burns are also often very common. We are going to be seeing a lot more this time of year. Irons, curling irons, flat straightening irons, grills, ovens, Kids often will touch their palms to an oven door that's down, or even sometimes the glass that's really hot. One thing that we see that families are always like, I have no idea, are fireplace covers. And toddlers who maybe last year were not exploring their house the way they are this year, walk right over and put their hand up. And these can be pretty deep injuries. Flame burns. Flame burns we more commonly see in our older patients, especially our teenagers who may be participating in more risky behavior and with less supervision. Matches, campfires, fire challenges. We've had some kids that come in with seeing things on YouTube, TikTok, where they are trying to light themselves on fire and put it out, and it does not go as planned. We also see a fair number of kids who play with aerosolized cans, matches, lighters, bonfires. It is important to know that flame burns are associated with more burn deaths due to smoke inhalation. However, inhalation really only occurs in a closed space. So most of our flame burns that happen outside at a bonfire, we are not worried about an inhalation injury the same way that we might be for someone who's in a house fire. Mechanical or friction burns. Commonly we see kids with treadmill burns. This got a lot of press this past year with the Peloton tread that was recalled. However, this is a pattern that we've been seeing for years. Just today in clinic, I saw 2 kids with treadmill burns to their hands. They are very, very deep burns and often require surgical intervention. We also see kids in burn clinic with road rash. So those are not your typical burn injuries, but we are managing those patients as well. Chemical burns we don't see as frequently. It is, I think maybe 2 or 3 years ago, we were seeing more kids with slime, making goo or slime at home and using ingredients that ended up causing chemical burns. Also things like detergent, Tide Pods. It is important to remember that neutralizing agents are contraindicated. We flush these with copious amounts of water, and poison control is always an incredible resource that should be utilized. Electrical burns. Fortunately, most of our patients with electrical burns are from household currents, which are low voltage, very different than some electrical burns that may be treated in the adult population, such as people working with power lines. For the most part, so an adult patient that has a high voltage injury, you are worried about their cardiac function. They get admitted for observation. Most of our patients do not require that. They need nothing at all. Or if they have a cutaneous injury, such as a burn, they get a screening EKG. And if that's negative, that's it. And they normally go home from the hospital, from the emergency room. They do not require admission. Frequent ones that we see, you can see this little kid's thumb. They were holding a paper clip. You can see the pattern of the paper clip, stuck it in a socket and got a burn. The oral one is from a kid that was chewing on an electrical cord. I can't remember if it was, I feel like it was related to Christmas tree lights. This is one that we are very worried about in terms of bleeding, and we would consult plastic surgery for that injury crossing the vermilion border. Let's go back and review the basic functions of the skin. It's important to remember that our skin is our largest organ in our body, and there are several functions, include protecting from infection, thermoregulation, prevention of fluid losses, sensory protection, and photoprotection. So when we have kids that are coming in with burn injuries, it's important to keep all of this in mind. Some things that are different about pediatric patients is skin is thinner, less resistant to heat. There is less subcutaneous fat, and they also lose moisture more easily. Also, in terms of the slower reflex, you may bump something and quickly pull away, but a child may not fully understand that and may have slower reflexes, causing a longer exposure and a deeper injury. So this is a diagram of our skin. Just remember, we have the epidermis, the dermis, and the subcutaneous tissue. This is helpful in understanding how deep a burn is in terms of the diagram and what extent is injured. Sorry, that's a pretty blurry slide. So our superficial burns are our first degree burns. These only affect the top layer of skin, the epidermis. They are pink or red. They can be painful and dry like a sunburn. They do not blister. These heal on their own with little intervention within a week, typically like 3, 4, 5 days. They can be very, very painful though, and they do not leave a scar. We sometimes do see patients in burn clinic with superficial injuries, but most of these patients do not require our care. Oftentimes they have a superficial injury in addition to a deeper injury that we are managing. And when we're thinking about the size of the burn, we do not include superficial injuries. Superficial partial thickness burn. So I'm going to go a little bit more than just first, second, third degree. Second degree burns are partial thickness burns, and we categorize these into either superficial partial thickness or deep partial thickness. So in a superficial partial thickness burn, which is a lighter second degree, we have injury to the epidermis and the superficial dermis. These burns blister. Anything that blisters is at least a second degree burn.
How do you feel about
Most of these burns heal within about 2 to 3 weeks and do not leave a scar. So they are blistered. Underneath the blister, the wound bed is often pink. It is blanching. It can be very sensitive. Both of these pictures are children with superficial partial thickness burns. A deep partial thickness is a deeper second degree burn. This burn would go a little bit deeper and extends into the deep dermis. They may be red, maybe more of like a beefy red, a hyperemic appearance. They can also be white. You may see some capillary bursts in the wound bed, almost like little petechia, little dots. They are, I think of a lighter second degree burn as a nice, even pink color. These are often more of like a marbled color, uneven, not the same throughout. There may be an area that's a little bit of a deeper injury, such as the chest here, that's more white, whereas the borders are more of a pink color. So these, they say plus or minus pain. I think that these are painful. They typically heal about 3 to 6 weeks and may leave a residual scar and discoloration. Full thickness burns extend through the epidermis and the dermis. The classic assessment or exam of these patients would be something that is white, brown, could be black. It's going to be leathery, dry, minimal to no pain, and may require skin grafting depending on the size and will leave a scar. Most of our patients, unless it is someone with a flame burn, do not have a deep flame burn, do not have just a uniform full thickness injury. Maybe if it's something very clear, like a direct contact for a prolonged period, but a lot of our patients are a mix of partial to full thickness, either just partial thickness, or if they're full thickness, also do have some component of partial thickness. So I hesitate when they say there's minimal to no pain, because many of our patients have a full thickness injury, but also have partial thickness that is painful. The little girl that one of the little girls I just saw in clinic that does have full thickness burns to her fingers from treadmill is getting no pain medication at home. I was surprised when I was talking to the mom. She said, nope, she hasn't been needing any pain medications. She sat through her dressing change and didn't move her hand at all. And that is a full thickness injury. So what we want with our burn history is we have several questions, and all of this information helps guide our management. So who is the patient with? What was the mechanism of injury? Right there, that's going to tell me, am I thinking it's maybe a lighter burn, a deeper burn? When was the patient burned? Burns can progress and change over time, so that helps understand the depth of the injury as well as the healing. Where was the patient burned? How were they burned? And then how have they been treated? In addition, we want to know about their medical history, especially with burn patients. Things that we're thinking about with medications and immunizations pertain to allergies, such as to sulfa drugs, or someone who has G6PD. That may limit us from using our Silvadene cream, which we'll go into, as well as immunization status. Because I'm wondering, is there tetanus up to date? So if it's someone that has a dirty burn, someone who was at a bonfire, threw something in, or lit a can on fire, is their tetanus up to date? If not, they need to be caught up on that. So Our next step would be to calculate our TBSA, or our total body surface area. This is an important component in that it's going to help us decide and determine what kind of care a patient needs. So there's several ways to calculate this. The rule of palm is a quick and easy reference. The patient's palmar surface, so their entire hand, including their fingers, equals 1% of their total body surface area. So if it's a quick assessment and we're looking, I will sometimes even take a patient's hand. I don't touch it to the wound, but I may hold it up and use it as a reference and say, 1, 2, 3, 4. Just to think about, is this a burn that can go home, or is this a patient that needs to be admitted? And if admitted, what type of care? We also have different apps that we use to for a more calculated assessment and measurement, and something that everyone can reference. Our new app, thanks to Cindy, is the Easy TBSA, and it is on you can download it on your phone. It is free. What we do is we put in the patient's information, their age, their weight, and then we draw. The picture on the left is from a different app, from the NSW app, but what we can do is you can actually trace each body part and calculate, and it will give you a total body surface area. When measuring TBSA of patients with facial burns, it's important to remember that they could be injured under their hair. Here's a picture on the left of a patient pre-debridement. So you look at it and you may say, this is a 5% burn. I'm just quick reference, probably more than that. You only see what is visible to you. Now, after further examination, it was determined that the burn did go into the scalp. And so her hair was trimmed. And before you know it, you're adding total body surface area. So this can significantly impact the patient's plan of care. And is an important thing for all of us to remember. So why does it matter? TBSA matters because it helps us determine the level of care that is needed for our patients. Now, there are exceptions to this. There may be a 1% burn that does need to be admitted, but when we're thinking about total body surface area, this is an important factor in, does the patient need to be admitted? If they need to be admitted, what do they need? Where do they need to go? So generally speaking, a patient with less than 5%, they can go home from the emergency room. A patient with 5 to 9%, that's someone that you should think about admitting, especially if it's a younger patient. If it's a kid that has something else going on, such as a cough, cold, has been having fevers at home, other comorbidities. 10% and up should be admitted to surgical care. Greater than 15% and up should be admitted to the PICU, and they will receive Parkland fluid resuscitation. In addition, I know that you guys have talked about trauma activations. Greater than 25% is a trauma activation. Greater than 40% is a trauma stat attending, our highest level of activation. Fluid resuscitation. So going back to the functions of the skin prevents against loss of fluids. Burns less than 15% total body surface area receive maintenance IV fluids. Patients greater than 15 are admitted to the PICU for Parkland fluid resuscitation. Regardless of whether they're going to the floor or the ICU, it is really, really important to remember that I's and O's for burn patients are essential and one of the most important pieces of information. So if you have a patient in the ER, if you have a patient in the ICU, a patient on the floor, and we're always asking what's the urine output, what's going in, what's going out, that is why it is helping us guide their resuscitation. So management guidelines of a patient greater than 15%. When do you start your fluid resuscitation? What do you do? Patients are often sitting in the ER. So in the ER, we do a rough estimate of our total body surface area. We pay attention and get a history of how much fluid was given by EMS or the outside hospital. And we want to start lactated ringers at 1.5 maintenance fluids. We cover the burns and we try to get them to the ICU in a goal of less than 60 minutes. Once they are in the PICU, we get an accurate weight. We do a debridement for an accurate TBSA, and then we complete the fluid resuscitation worksheet. In addition, a Foley catheter is going to be placed because that is going to help guide our fluids, and then also place an NG for feeding and get that going as soon as possible. Parkland formula helps us determine the patient's fluid requirements. The way it is calculated is 4 times the patient's weight. So 4 mLs times the patient's weight in kilograms times their total body surface area. This is why it is important for us to know their TBSA. It is also very important to know how much fluid they have already been given because this factors into our resuscitation. So we have our calculations. I'm going to show you the worksheet that we use next, but half of the fluid is given in the first 8 hours, and then the subsequent fluid is given in the next 9 to 24 hours. Patients under 30 kilograms should also receive a separate maintenance IV fluid of D5LR. This is in addition to their Parkland fluid. So they get Parkland resuscitation and they get maintenance fluid for patients under 30. Now, important to remember that Parkland is guiding us. It is our starting point only. And that Parkland, the amount of fluid they're given is titrated based on urine output. The goal urine output, depending on the weight, is 0.5 to 1 cc per kilogram per hour. As needed, based on how much is coming out, the fluids are increased or decreased by 1/3. That is the Parkland formula. The maintenance fluids are put on that pump set and they are not touched. This is the fluid resuscitation worksheet that's used for major burns in the ICU. On the columns on the left, it's probably hard to see on your screens, but we put in the patient's weight, the total body surface area, then we calculate, and this gives us our starting point. From there, nursing enters the I's and O's, and the worksheet prompts titration according to the output. In addition to IV fluids, nutrition is essential. Burn patients are hypermetabolic. They require increased protein and calorie requirements. Their baseline nutritional needs are insufficient. So we might say, oh yeah, they're eating well, but we need to know how well are they eating. Depending on the size of the burn, patients may require 2.5 times more than they normally would need at home. Many of our patients are admitted only for I's and O's and PO assessment, so it's really important to think of nutrition as an essential medication for these patients. In addition to enteral feeds, that is automatically started for patients over 10%. They also get a high protein, high calorie diet. They can PO ad lib. We need to keep track of how much is going in. Multivitamins, larger burns are often started on supplements like zinc and ascorbic acid. And it's important to educate families from the get-go about the role of nutrition. You can help guide families in making smart choices, something like choosing milk over water or juice, or if we're doing something like juice, we're gonna ask for a supplement like Ensure Clear or Boost Breeze. Many of our burns, our toddler burns, have facial burns. And so then the question always presents, how do we secure the NG tube? Nutrition is so important for these patients. A nasal bridle can be placed to secure the tube without taping it to the face. This is a diagram of how it's put in. Oftentimes it's put in the OR. It can be put in at the bedside. An important pearl for nursing to remember is you can remove the NG or even replace the NG without removing the bridle. So it is that string that connects it and holds it in place, and you have a little trap door there that opens and closes for the NG. So if you have a patient you're thinking we don't need the NG or the NG is clogged, open it up, take it out. Do not cut the string. Once the string is cut, the bridle is out and is going to be removed. So burn treatment, our first step after fluid and determining where a patient's going to go is burn debridement and dressing changes. So first thing to think about is pain control. These patients are hypersensitive and we want to avoid a painful exposure, especially during the first debridement. So we want to advocate for pre-medication. We want to have a plan, whether it is an oral medication such as oxycodone, acetaminophen, ibuprofen. In the ER, we frequently do intranasal fentanyl if they have an IV morphine. And then also if it's a bigger burn, then we think about, do they need conscious sedation with ketamine or to go to the OR with anesthesia. So the pre-medication is important, not just the initial dressings, but also throughout their hospitalization and as well once they go home and when they come to clinic. So encourage families before they do burn care, try to give a dose of pain medication, even if it's a dose of Tylenol 30 minutes before. If you are discharging a patient who is going to be getting oxycodone, an important thing to remember is that liquid oxycodone is very difficult to get in most community pharmacies. So if it's a patient that is leaving and they can, I would encourage them to fill it at Walgreens. It's one of the medications that when Walgreens opened, they asked what medications we wanted, and we were like liquid oxycodone. If patients are coming to clinic and are going to be just getting a single medication before their clinic visit, they can even fill it before their appointment. We do have oxycodone in clinic, but it requires a wait for a pre-medication. So it is best if families can fill it and take it the morning of their appointment. Debridement. Why do we debride? So this is a picture of a patient pre and post debridement. Debriding is going to help with healing. It's going to help prevent infection. It's also going to help us assess the depth of a burn injury. So the picture on the left, and we're going to go into assessing it, but that was described initially. It was a patient from their pediatrician. It was white, it was brown, concern for full thickness injury. That is before it was debrided. That is exudate, it is dead skin. Post debridement, we see that the wound bed is pink, it's moist, it's blanching, it's not a full thickness injury. It still needs to be managed and cleaned. But that is an important consideration. Also, you can see on the left that that big blister that was probably there, it is open. So the skin's protective barrier is disrupted and germs can get in. So we want to be putting a medication directly on that. There is, I'm going to skip it for now in terms of time, but we have wonderful videos on YouTube. And there is a video about how to debride a burn that Liz did and Cindy for patients in the emergency room, talking about supplies and how to debride. If you are going to be doing any sort of debridement or dressing change for a patient, number one thing, and this video talks about it, is have your supplies ready. Think about what you're going to be doing, what you need, and have everything available and ready to go. Because once we start undressing these burns, they're very sensitive, they're uncomfortable. We want to get them covered as fast as possible. So when do we consult surgery or the burn team? We are part of the general surgery team. So this is a list of criteria for patients in the emergency room when to get a consult. Any full thickness burn to evaluate whether or not it needs surgical interventions such as excision, grafting, anything greater than 5%, where we're thinking about do they need to be admitted. Younger patients are at higher risk for bounce back. The other thing is location of the burn. Location may present more challenges regarding care. Mechanisms here are often associated with full thickness injuries. Anything that we're concerned about for child abuse or non-accidental trauma, NAT, we're always thinking about the history. Does that make sense? What's the distribution? And patients with fevers. So we talked about the skin's protection. It is a barrier to help prevent infection. That barrier has been disrupted. These patients are also at increased risk for other infections such as a viral illness. Their bodies are in overdrive and they are just overall more susceptible for getting ill. We have a lower threshold of admitting burn patients who do have fevers or are sick at home. So what do we put on our burns? We're going to go into these, but see, these are some of the most frequent burn dressing changes that you will see on the floor, in clinic, in the ICU, in the ER. So we have two categories of dressings. We have long-acting dressings, other than surgical intervention. We have long-acting dressings and we have daily dressings. So things that we have to think about: the depth of mechanism of injury. Are we going to get the coverage that we need from that type of dressing? The location, such as a face, genitalia. Does the patient have anxiety, pain control? And then also that I do factor in some sort of family patient preference. If you have a teenager with a burn and they say, I really want to get in the shower, then that's something important to think about. So long-acting dressings minimize painful dressing changes. So we do prefer to use those with our younger kids as much as possible. They're also associated with a decreased length of stay in the hospital. Daily dressing changes we do use frequently for patients with full thickness injury that may be dry with eschar. Our long-acting dressings won't penetrate those injuries. Anything that we're concerned could be infected. And then when I was saying location, face, diaper area, it is important to remember that these do get cleaned with burn care. Frequently, families are told, no, I was told not to clean it, not to clean it, not to clean it. They go, every time that you are changing a dressing is an opportunity to, and the burn should be cleaned. So our most common long-acting dressing is Mepilex AG. This you will see throughout the hospital, frequently put on patients in the emergency room. We use this for nice, healthy, partial thickness injuries. It is a silver impregnated dressing. When we say Mepilex, we mean Mepilex AG. We do not mean Mepilex border. We do not mean Mepilex transfer. We should be better about specifying that. But if the burn trauma team is talking about Mepilex, Mepilex AG, that means it has medication. It is silver impregnated. It is soft. It has a silicone pad, antimicrobial. It can stay on for about 5 to 7 days. For patients in the emergency room, we typically have them come back about 3 days after the injury so we can reassess it and get the dressings changed. An important thing to remember is on the back there is a plastic side that gets removed, sticky side down, secure it with Curl-X and tube it fast. Another long-acting dressing that we use is called Acticoat. This is going to give us a little bit more penetration than Mepilex AG. It allows for draining through the dressing. It's like a mesh, silver mesh netty material. We often use it with Mepitel for ease of application and removal, but it also can stay on for about 5 to 7 days. It has broad spectrum coverage, including our MRSA, Pseudomonas. It is flexible, stretchy, and it allows for exudate to transport through the dressing. An important thing to remember is because exudate can go through the dressing, it doesn't have a built-in sponge per se. A lot of times we use a pad on the outside to absorb the dressing, absorb the drainage. Also, there can be more discoloration associated with this. That brown, gray medication of the Acticoat can transfer with liquid. So sometimes even around the edges, people will see it looking brown or yellow and think, oh, it's infected. And it more often, typically, is just the exudate. So our daily dressings, most commonly we use Silvadene and Sulfamylon. We use these for deeper injuries. They are going to be used often for full thickness or a dirty injury. They are topical antimicrobial and have better coverage and eschar penetration. These do get changed daily. They are cleaned. The wounds are cleaned with each dressing change. If you are going to be changing Silvadene for one of your patients or Sulfamylon, you can put it directly on the wound, but we typically recommend taking gauze, putting it on the gauze like you're buttering toast and laying it on the wound. That is going to cause less touching and repeated trauma and pain for the patient. Another daily dressing that we use is Xeroform. We typically use this on partial thickness burns, buttocks, face, scalp. It is a mesh impregnated with petroleum and bismuth. It is bacteriostatic. It keeps the germs out. It is going to protect the wound and hydrate. Bacitracin is another topical that you may be using, and we typically do that 1 to 3 times a day. Facial burns. So faces are exposed. It's very difficult for us to wrap them. It is difficult for families and patients. They have significant swelling. Eyes may swell shut. It is a very difficult injury to treat. The good thing about it is faces actually heal very, very well. So oftentimes patients' faces heal within the first week. So we may see a kid in the first few days, they're swollen, their eyes are swollen shut, they're very exudative, and within a week or 2, they're often epithelialized new skin. So our goals for facial care is to keep the wound clean. We're going to keep it moist. We're going to expect swelling. So if you have a patient that comes in with a facial burn, it is helpful to tell the families this may get worse before it gets better. Swelling is okay. It is to be expected, especially periorbital. It does not take much for the eyes to get very swollen. Another thing that you can teach families from the very beginning is we want to protect it from the sun. We want to protect all of our burns from the sun to prevent secondary damage or long-term scarring. Most of our burns initially are wrapped and covered, but a face is not. So if they're going to be outside, we want them to have a hat on. Once they're healed, they could do sunscreen, but from the very beginning, that's something for us to remember. The other thing that we can start teaching from day 1 is how to care for the burn, because this is something that families, when they go home, they are going to have to do facial care. And as I mentioned, it's very distressing. Families are often met with this like shock of, you want me to do what? So from the beginning, start teaching families, this is what we're going to do. This is how we're going to do it to help with their comfort. We do also use wash. Wash helps debride the dried exudate, the dead skin, and really penetrate. The most important thing with wash is not how much you use, it is soaking it. So oftentimes I will take a single 4x4, soak it, put it on, put a telfa over it, secure it on their head for 5-10 minutes while you go about doing the rest of your care. And then in the end, when you take that off, it's going to have started working its way through that exudate, softening it up and making care much easier. I also always tell kids it smells like chlorine. So if they're not expecting it, it can be a big shock. It is okay to go in the eye. We don't pour it in the eye, but it's not going to hurt them. It's okay if a little bit gets in the mouth, but it is a great addition. A lot of times we'll order it for patients in the beginning. Once their burns begin to heal and they're dry, unless it's another part of the body that we're still managing, but specifically for faces, we often don't need it. So if you see that it's still ordered and the face is epithelialized, you can always mention that to us and we can discontinue that order. So we also may use erythromycin around the eyes. That was another thing. So when I say face is healed very fast, this is, I know it's hard to see and you can't see the side, but this is a girl the day of her injury in the emergency room. And on the other side is her 11 days post-injury. So there is still some discoloration you can see along her forehead, but her face is healed and there is already return of pigmentation. So it is like night and day for these kids. Another really important member of our team are our physical and occupational therapists. So our therapists see patients in-house, sometimes in the emergency room while they're admitted, as well as outpatient in clinic. They help us with range of motion exercises. They help with splint fabrication. They're also involved with our scar management, see patients for compression garments. So the pictures here are for splinting. One of the most common splinted areas that we do are hands. So when we talk about contact burns, contact of the palms that are full thickness, treadmills to the fingers, we really worry about hands healing like this, which is our natural resting position. So from the get-go, we start talking about range of motion exercises, splinting to keep them open. If you are doing a hand dressing change, reviewing with family from the beginning, we want to wrap the hand in an open position. The pictures are of a palm splint, and then there's also, it's hard to see, but these are finger splints. The little boy on the right, that is a compression garment that we put patients in after their burns have epithelialized for patients who are at increased risk for scarring. So patients that have had full thickness burns, skin grafts, family history of scarring. The gentleman in the top of the picture, he is also wearing a compression garment. That black shirt is a custom made garment. They're measured. They can have inserts. The little boy in the blue shirt has some sort of a pad against his chest, which I assume is the affected area. This is a doll we have in our office of compression garments. You guys won't see them as much inpatient. Some of our bigger burns that do stay here past healing do get put into interim garments. They are to be worn ideally 23 hours a day, so it takes a lot of compliance for families. Social work. Social work is also an important part of our team. Social work is to be consulted on all patients, all burn patients under the age of 2 in the emergency room. We also obviously get them involved when there's any concern for an inflicted injury or neglect. Also, they're very important for family support. Outpatient clinic. So I mentioned we do have clinic here at Children's. We also have clinic at Friendship Heights, but our main clinic is here 3 days a week. We have clinic Monday, Wednesday, and Friday. Our clinic is run by nurse practitioners. We have burn surgeons who will evaluate our surgical patients, but it is staffed by myself and my colleagues. In clinic, we also have a dedicated burn psychologist, which has been a tremendous resource for us, for patients, for families. One of the things that we talk about are with the major injuries, our patients with 30–40% burns, it's kind of a given that there's a lot of family stress, but even patients with small scald burns, it can be very disruptive and very stressful for the entire family. Oftentimes families are around, it's a period of crisis. What do we do? There is pain associated. So getting back to normal after hospitalization or even just after any injury is really important. So our psychologist, Carrie Tully, provides a tremendous resource for our families. We also have a dedicated child life specialist in clinic. Back to the slide where we talked about pain management. As much as possible, if you are going to be doing burn care and you have access to child life, please consult them. Please, even if our team doesn't think about it for us, remind us, reach out to them. We welcome them for any sort of procedure or dressing changes. I mentioned physical and occupational therapy. Our outpatient clinic support also includes things like scar and laser evaluation. So our deeper burns are patients with increased scarring or hypersensitivity and itching. They could possibly get laser therapy, which is something that we do for our healed burns several months after they healed. So when families are worried, one of the things they always want to know is it going to scar? And it's hard to say. It often depends on how long it takes to heal. But there are resources that we have to use to help treat and manage scarring. So for nursing, for burn education, you guys play such an important role with educating our families from the get-go. As I mentioned, it's a stressful time. There's a lot going on. So from the very beginning, if we can focus on nutrition, fluid, pain control, sun protection, and then also thinking about safety and after the burn. The after the burn videos, Sydney also deserves major credit for this. I have to tell you, I was actually looking at them again this past week and was reminded of what incredible resource they are, not only for families, but also for us. I was talking to our child life nurse psychologist today in clinic about really needing to emphasize these because there is so much information that is given to you during the emergency room or clinic. It's a lot to process and it's a great resource for families. These are also, I think, and maybe Cindy, you can confirm or not, I think they're all on the Get Well Network, or most of them are on the Get Well Network.
Yes, they are all on the Get Well Network and they're orderable through Cerner.
Yes. So some of them will auto-populate for you in the burn admission. If the burn admission orders are used, some of them will populate, but there are more that are not even selected in there. So if families have questions, if we are talking about nutrition, what's your stay in the hospital going to be like? I have questions. Tell me about the burn injury. I don't understand. Or we've reviewed this burn dressing and I still have questions. What am I going to do at home? How am I going to change my patient or my child's dressings at home? These are on YouTube. Hopefully they are also given in D-part instructions, but they have lots of categories here: home safety, burn prevention, first steps to the emergency department, understanding a burn injury, skin grafting and laser treatments, stay in the hospital, stay in surgical care, PICU, nutrition, at-home dressing changes, coming to clinic. So it really covers everything. And I would I know sometimes we glance over the Get Well Network videos, but I would really encourage you to reference them on your own and also to encourage families to use them. So what does a healed burn look like? This on the left is a superficial partial thickness burn. On the right, this is what an epithelialized burn looks like. Another thing I like to try to tell families from the beginning is we are going to say your burn is healed. It is still going to look different. That color return can take weeks to months. So the picture on the right is a healed burn. There is new skin, but it has increased vascularity. It's more pink, it's more red. The pigment has not returned. That takes time. So some of our inpatients, oftentimes the kids that are here for longer stays, often their burns are healed before they go home, parts of them, or a facial burn may be healed. So if it is pink, if it is dry, if it's blanching, not dry because it has overlying exudate, this is what a healed injury looks like. And then we're going to transition to moisturizer, massage, and sun protection. So I think, yeah, I have some more time. So just to kind of go through fast, I don't expect you guys, this is more outpatient, but the basics of scar management and prevention: moisture, massage, minimize sun exposure. What do we use for moisturizers? We use any sort of gentle moisturizer. We mostly use Aquaphor here in the hospital. That's what we have. If people don't like something really greasy or thick like an emollient, they can use Aveeno, Eucerin, cocoa butter. We want a gentle moisturizer, put on, not so much like pooping it on, thin layer, massaging it in. The massage is going to also help strengthen the skin. It's going to help desensitize the skin. sun protection, in addition to something like protective clothing, like a hat or a shirt. We do recommend sunscreen once a burn has epithelialized. So once it is healed, families can put sunscreen on it. We recommend a sunscreen with zinc oxide, a mineral-based sunscreen, but really protective clothing is going to be the easiest way to do it. So going back to like this kid, the family can goop them up in sunscreen. If I were seeing them in clinic, I would recommend that they get a sun shirt. If it's the middle of the summer, they're going to go to the pool, they can put a shirt on, they don't have to worry about sunscreen. They're also going to protect the burn in questions. And we like to not hide it and talk to kids about what we're going to do, how we're going to answer questions, but sun shirts are great. This is old. Unfortunately, we have not done the sun shirts in a few years, but we previously were selling sun shirts that we had put our logo on, and for each one bought, we would donate one to one of our burn patients. Advanced scar management. So anything that's going to take longer than 3 weeks to heal, we are more worried about developing a scar. That could be a thick, raised, firm scar with discoloration. It can be uncomfortable. It can be itchy. It can cause restriction in range of motion. We work with our physical and occupational therapists. We do compression garments, silicone, steroid injection, scar excision, and laser therapy. So as I mentioned, anything that's greater than 3 weeks to heal, high friction areas, burn scars tend to peak about 4 to 6 months post injury and can improve over the next 1 to 2 years. And this is just a picture of one of our patients in a sun shirt. So I know that was a lot of information and a long session, but if anyone has any, we'll skip for prevention, but if anyone has any questions, I'm happy to answer.
Catherine, that was great.
Thank you.
That was really good.